make changes in someone's care using that kind of technology. So the idea that an insurer would, and I'll back up, insurers in this country at least have historically taken over some of the support functions for clinical care because it wasn't happening out in the practice. And so our clients, large industries, were coming to us saying, somebody's dropping the ball here. These patients have diabetes and they're not getting the testing done, they're not getting, the appropriate care. What are you doing about it? So we developed this infrastructure of health coaches and nurses and utilization management functions that rightly belong in the provider setting if we figure out how to do that. Technology allows that, having full information at the point of care, being patient-centered, so we use technology to really let the patient be in a situation where they're being cared for appropriately. So it's a natural evolution. UPMC did it being a provider, gradually getting into the insurance business. You're finding insurers starting to get into the provider business where you can truly integrate and get synergies. But I think technology is very much a driver, and the data as to how you would do that effectively.
Well, clearly, if you're in both the insurance business and a provider, that gives you a lot more information about each patient, a lot more data, a lot more to work with, to analyze. But is there also an issue of having too much information about a patient? Is it intrusive? Are there issues for patients that come up because of that?
Well, patients technically can opt out of people sharing their information, but it's to their disadvantage. Ultimately, you want people to know as much about your health at the point of care as you can, because without that, we end up with very disjointed care. I mean, many, many examples of people, and seniors are particularly vulnerable. They go to multiple physicians for multiple problems, and the team doesn't talk. They may not have full information that says, oh yeah, I know they were prescribed 2 drugs last week by a different doctor. And so you have polypharmacy issues, drug-drug interactions, you have people not getting optimal care. Interactive electronic health records help with that. So in a system where you have everybody on the same electronic health record and they can see what happened recently, critically important to assuring optimal care. So I feel strongly that the privacy issue is not one that the patient should worry about, that their doctors need to work together as a team. And it's not just the doctors, it's everybody who's in the caregiving arm that's practicing to the top of their license.
And I noticed that Highmark is working with Carnegie Mellon University's Center for Disruptive Medicine, which sounds interesting and disruptive. Can you tell us a little bit about that and what it's doing to your work? And it may be that UPMC is also working with Carnegie Mellon on that. So after Donald speaks to it, maybe you could, Harun.
So we're very proud of this relationship that we formed. And it was when Allegheny Health Network was formed and became part of us. We looked for an academic partner, but we looked in a fresh way. And UPMC has had the traditional academic partners in the health sciences, which has been a great benefit over the years. What we looked at was said, Carnegie Mellon University has tremendous resources and aptitude in computer science, in engineering, in business. Let's put problems in front of them that are not typically ones that they are asked, and say, how can we get the health sciences and the engineers and computer scientists and business people to think through a problem in an innovative, perhaps disruptive way that will come up with a solution that will provide better quality at lower cost. We have, as Highmark Health, the parent company, and again, we're a very complex organization with lots of subsidiaries, but Highmark Health as the parent said, we're going to put money into this Disruptive Health Technology Institute, in essence, seed funds, and we have asked a series of questions through a series of RFPs to the scientists at CMU. and said, come up with a solution. And a great example is one around colonoscopy. And they are partnering with a provider who recognizes one of the issues with colonoscopy, you can do screening colonoscopy, and yet there's a cohort of those people who get screened who say you're just fine, who come down with colon cancer in the next year or two. Why? Because somehow it got missed. Because the technology, as you're doing the scope, you may not look at every corner of the colon, and you could miss a polyp. So they're working with the scientists at CMU to say, let's do the equivalent of Google mapping of the colon. And we can tell you when you're done, what percent of the colon did you actually visualize? Where did you miss? Go back in and look at this corner. You didn't go down that street. Can you get that seen better? So this concept of using computers to assist with colonoscopy and assure that every provider, no matter how well trained they are, has seen every section of the colon could be revolutionary in how this is done and prevent those misses of colon cancer. We do a pretty good job once people get their colonoscopies, but there's still people who are getting missed even though they had the effective, so-called effective procedure.
And Harun, of course, UPMC is related to the University of Pittsburgh. You're a part of it in a way, and you partner a lot with Carnegie Mellon and other universities, not just here in the region, but all over the country. I wonder if you could talk a little bit about this notion of disruptive technology and partnering with academic institutions to help you innovate and create new solutions.
So I think the other piece of that may not be a well-known factor is that within UPMC we have a division called Enterprise, and that division itself is basically a body that allows us to create innovation. So while we have partnered with Carnegie Mellon and also with the University of Pittsburgh on the areas of disruptive technology and innovation, we actually also have a division within our UPMC that goes out and looks at lots of different technology solution vendors. Because what has happened in this industry, a lot of these vendors have identified technology and they just want to ram it into healthcare, thinking because it has worked really well in the banking industry or the finance industry or marketing, that it's going to work really well in the healthcare industry. Unfortunately, that's not how it works. Most of those technology is not designed for a physician workflow. It's designed maybe for a billing workflow or some other workflow. And so what we have to do is we've been partnering with a lot of these vendors and saying, let's talk about how to make UPMC and the 22 hospitals an incubation center where we jointly develop these technologies together that apply to what we do within UPMC. We are the perfect place for testing those models to see if it really changes what we want to do as in terms of an outcome, and then let's figure out how to take it to market and really make a benefit to all the other healthcare organizations. And we're doing the similar things with Carnegie Mellon and also with University of Pittsburgh. One case we'll talk about is we're significantly involved in the analytics engine of UPMC. And in the pediatric side, we in the last 2 years, with the help of our foundation at Children's, we were able to raise enough money to work with the University of Pittsburgh, and we went after scientists. We didn't go after the traditional nurses and doctors because they know the patient and they're very close to the patient and they can tell you they're providing excellent care. But sometimes there's subtle things that gets missed and we're not able to identify those. So we have to bridge that by using innovation or machine language, as I call it, to be able to identify, to say, what happened? What did we miss? And allow those machines to be able to, behind the scene, to identify issues so that we can provide what I consider an early warning trigger to our caregivers so that they can go after and identify how to take care of that patient before something goes wrong. The simplest way I can identify this is every one of us have a vehicle, and the vehicles have alarms that go off when something is about to happen. If you leave your door open, if you're going to run out of gas, your car does not tell you you have ran out of gas after you ran out of gas. It's giving you a warning, early warning. And that's what we're trying to do, is to get to the analytics engine with the technology and the partnership to say, how can we predict readmission back to the hospital? How can we predict patients that are at risk of being transferred to the ICU? And what we have identified is that 4 to 6 hours before it happens, there's actually subtle things that are happening that we don't consider them to huge, but they're all basically, when you put it all together, it tells a story of something about to happen. And so we need to react quickly. And that's what this partnership is going to do, is bring in some of the best minds in the academic center, our clinicians and the partners, to come together to create what I consider a new wave of how to deliver medicine through innovation and a focus on quality and outcome.
Fascinating, thank you. Brian, excuse me, I'd like to turn back to you now for a minute. In your line of work, all of a sudden a crisis happens, and you're involved in intervening and solving that crisis. So all of a sudden, from a low-level involvement, you're suddenly involved with insurance companies, medical providers, emergency services, other kinds of companies, local governments, the United States government. What sort of opportunities does this sudden immersion in all these different environments give you to pull together a lot of information and data quickly, both for the short term to solve the problem you're working on, and for the long term to make your business better?
Yeah, the availability of medical information is instantaneous for us. When we have for example, if we have a patient who is perhaps a burn victim and they're in a hospital that doesn't have a burn treatment facility, and we've got to evacuate them out, we're able to get all of the information uploaded to our system, have it analyzed by our doctors and our medical transport people to make an evaluation to transport or not. So the availability of information, as everybody's discussing, the analytics are there. It's very easy to upload. We get connected very quickly. We're able to discuss with doctors in real time what's happening, make evaluations as to whether a patient should be transported to a different facility. And it also allows us to do evaluations of facilities. People travel to all corners of the world, and they get injured and they get sick, and we have to be able to assess the facilities that they're in and make immediate determinations as to whether that hospital is suitable for that patient or not, and then make the decision to transport them. So it also is the analysis of the treatment facilities and the hospitals and the clinics that are out there in the world to determine their level of service. And this availability of information, the availability to do all this from various locations is critical to our business. Because if we can't make those decisions properly, then we're not going to deal with the lives of our members in an appropriate way. So we look at it as great opportunities because people are traveling more. If you look at the statistics, everybody is traveling a lot more. And that's great because people are going to learn a lot more about each other as they travel globally as well, which will help us sort of connect and unite. But it also gives us opportunity to go into new markets and expand and be able to provide first-class services to people across the globe.
Does having this sort of information put you in a position to offer proactive services or advice? Do you offer travel advice to people? Someone who has a special condition, you might want to consider going to this part of the country, but not that part of the country.
Yes, we do. We have what we call a pre-trip evaluation, pre-trip planning. So whether it's a medical condition that people are concerned about, or perhaps parents that are concerned about their students, because we have a lot of student population in our business as well. They may be concerned, my child is a diabetic and he's going to this location for a summer abroad or a semester abroad program. What do we do if this happens? So we do a lot of this pre-trip planning to put information in the hands of the people that need it so they can make the best choices while they're traveling and know what to do if the situation should arise.
Thank you. Interesting. So as much as I like to think I'm a great questioner, I'm sure I've missed some things that one or more of you would like to comment on. So I wanted to give you a chance to jump in and answer a question I forgot to ask. Some thoughts?
Well, a thought jogged my mind around process engineering that is something that really hadn't happened much in the healthcare space. We decided, and others have done this as well, that we have inherited lots of ways of doing things, and we just keep doing it that way. Very often the frontline staff know that things are broken. They know where the rework is. They know that that process is just something that was always done that way, and it's, you know, the Highmark way or the UPMC way. It's just the way it was done. Industry had embraced rapid improvement events, Toyota Production System, you know, process reengineering, Six Sigma, Lean, many, many years ago. The knowledge about quality control in industry existed for decades. Yet it was accepted in healthcare that we're doing the best job we can. And, you know, Paul O'Neill, who I think does have a role in the American Middle East Institute, former CEO of Alcoa, was very, very disturbed about 15, 20 years ago about the quality of healthcare in the country, and particularly in Pittsburgh, where he could have an impact on it, and pulled together a group of people from industry, from health plans, from the universities, the providers, to say, this needs to be fixed. I don't want to hear anymore that infections just happen and that's the cost of doing business. The right rate is 0. So starting to do quality improvement using things like Toyota Production System in the hospitals, you saw certain places where the rate of infections that had been, you know, exceedingly high went down to 0. We've also begun to do this now with process engineers in the health plan. Nobody's dying in the health plan, okay? They may be dying out in the hospitals, but we also are wasting a lot of money by doing things in ways that really have never been analyzed and process flow mapped.
And your goal, of course, is to bring our rates down, I know.
Exactly, exactly. You know, we want value for every dollar that's being spent. And I can tell you just this past year, I set goals in my operational area to take out $4 million of operational costs from process reengineering. And we're almost $5 million right now. So I think this is something that needs to be embraced in the healthcare space, re-engineering what you do, using techniques like Six Sigma to be able to get better value out of the healthcare dollars spent.
Good point. I wonder, Harun, if you have anything to add to that, because I know UPMC did a bit of a trial with the Toyota Production System and then evolved to a sort of a quality enhancement system. Maybe you can make a quick comment on that.
Yeah, so we have a number of quality initiatives, you know, all the way from Six Sigma and to, you know, some of the things that we have been doing in the clinical side to enhance our programs around the world, in, you know, whether it's, say, getting ready for international JCI certifications or something so simple as just achieving a electronic health record status where we can be a digital campus. And there's a lot of variations of interest in the Middle East from our counterparts to assist them with, you know, how do we maximize the value of their healthcare program using the UPMC's methodologies. And the challenge is, it's a journey. You know, we started 10, 15 years ago. Unfortunately, you know, it's hard to shrink everything into a 12-month period and say, here's a cookie cutter model. Unfortunately, we don't have that kind of a you know, magic ball that we can put in front of it. But I think that we work with them collectively, like we have done in Italy and other countries, to ensure that we are able to establish the best program, best quality outcome for those organizations in the Middle East and in Europe and around the world.
Thank you. Brian, a last word?
Last word.